Hello everyone. We were studying about hepatic disorders, chapter 80 of the Tintinallis. So today's part 2. I've just realized that it is a very long chapter, so I think that it is going to take part 3 also, because it's a pretty long chapter, and I think that I won't be able to cover it today. So last class we were talking about the liver enzymes, right? So the lab increase of certain enzymes we had done, AST, ALT most importantly, and this was the last slide, ALT and AST. So ALT is more specific, whereas AST is also secreted by the heart, smooth muscle, kidney, brain, and it is also raised when a patient is on all these drugs, right? So this is what we had done. Next enzyme was the GGT. So GGT is what? Gamma glutamyl transferase. So transferase, it is stimulated by alcohol most importantly. So in alcoholic hepatitis, or patients who are chronically on alcohol, consume alcohol very regularly, they may have GGT raised, right? It is also increased by inducers. We know about enzyme inducers, right? So if there are any enzyme inducer drugs like phenobarbitone, most important, warfarin, these will increase microsomal enzyme activity, and whenever microsomal enzyme activity is increased, it causes raised GGT levels in the blood, right? Now, it is also increased in few situations, like inflammatory situations in the body, like pancreatitis, then rheumatoid arthritis, then MI, then diabetes, then rheumatoid arthritis I've already told, then uremia, uremic gastritis, etc., then COPD. So these are few conditions where GGT is raised, right? Then if GGT is raised GGT, and there are features of hepatitis, most likely it is an alcoholic etiology. So alcohol is the most likely cause of such presentation, right? Now let's talk about ALP. GGT we have completed. Now let's talk about ALP. So ALP is seen in biliary obstruction, right? Biliary obstruction, which is known as the obstructive jaundice, right? It can be because of CBD stone, it can be because of SOL, it can be a head of pancreas, CA, head of pancreas, it can be anything, right? See, if its level is more than 4 times the upper limit of normal, then it is likely that there is cholestasis. Bile is not able to pass through, right? Non-specific marker ALP. Why? Because also it is derived from bone, it is also derived from placenta, it is also derived from intestines, from kidneys, just like the AST. This is also a very non-specific marker. Okay? WBC is also, right? They also secrete ALP. Also, it is up to double, like more than equal to 2 times is normal in pregnancy. So in pregnancy, physiologically, ALP levels will be high. So in so many situations, ALP levels are increasing. It is very, very, low sensitive marker, but okay. Then let's talk about LDH. Very non-specific once again, lactate dehydrogenase. It is a non-specific marker. Then it is seen in all hepatocellular disorders. But it is not seen in obstructive jaundice, not seen in cholestasis. So if it is obstructive jaundice, ALP will be high, GGT will be high, OTPT may be increased if it is a diabetic person, but LDH levels are going to be normal, right? If hemolysis, excessive hemolysis is occurring, then what will you see? You will see that LDH levels are going to increase, plus unconjugated bilirubin is going to increase, right? Then let's talk about ammonia. serum ammonia levels, right? So ammonia, how is it produced? What happens is that all the amino acids contain nitrogen. Other dietary things like carbs, carbohydrates also contain, aldehydes also contain. These are the diet, the sources of all this is diet, right? So from diet, whatever we are taking, if it contains nitrogen, this nitrogen containing compounds will be metabolized by liver. Right? And after that, it forms ammonia, NH3. It is converted to ammonia, right? Now, if hepatic metabolism is reduced, what is going to happen? Ammonia levels will increase. Right? Why? Because it was getting metabolized, but now it is not getting metabolized. So overall it causes a poor prognosis. We are going to read about it so much. Like now 10 minutes later we are going to read so much about ammonia. So let's just keep it in our mind that if ammonia is increasing, it means poor prognosis. Just remember this much, this one line. Let's talk about PT, prothrombin time. You know factors 2, 7, 9, 10. I don't write it in Roman letters, please. It takes so much of time. So these are the vitamin K dependent coagulation factors, right? So these are synthesized by liver. So the anabolic function or the synthetic function of liver, as discussed in the previous class, anabolic function of liver is reflected by these and also by the prothrombin time, right? So the true measure of liver function is prothrombin time. Okay. If PT is prolonged in acute hepatitis, it is a rare thing and it is considered to be very, very serious. Okay, it is considered to be very, very serious. Okay, it indicates that the disease is severe. Disease severity is very high and hepatocellular necrosis is occurring. So prothrombin time is rarely raised in acute hepatitis, but if prothrombin time is found to be high in acute hepatitis, it indicates that the disease has progressed and we need to immediately do something, right? Now let's talk about normal liver. Liver is normal, still the prothrombin time is increased, which means what? LFT is normal, CBC, KFT, ultrasound, symptoms, everything is more or less normal, but still you are seeing that, oh, the prothrombin time is increasing. Now what does that mean? It means that there are many other things which may cause increased prothrombin time, one of which is malnutrition. Malnutrition can be psychological also, psychiatric disorder, which we have read. Then I forgot the name of that disorder. Bulimia nervosa, right? In that bulimia nervosa, what happens is the patient does not eat. So this psychiatric malnutrition may lead to prothrombin time, which can be raised. Then what else can be there? It can be celiac disease. It can be malabsorption syndromes, right? It can be celiac disease, I've told you. Yeah. Then what else can be there? There can be, post-lap resection and anastomosis. Like if laparotomy has occurred, then some part of the bowel is out, so the absorption cannot occur, right? All these type of conditions also cause prolongation of prothrombin time. Now, see, if I say that liver is normal, prothrombin time is raised, and vitamin K levels are low. It means what? That vitamin K is also low. So vitamin K is low. We have to check whether it is because of vitamin deficiency or whether it is because of liver problem, right? So prothrombin time is raised, LFT is deranged, let's take this, no? You have two patients, right? Both of them have the same situation. Prothrombin time is raised, LFT is deranged, and that is why the levels of vitamin K is low, right? Or you can say that 2, 7, 9, 10 are reduced. Now what you will do, to both the patients, you are going to give what? 10 mg, 1 ampule basically, vitamin K parenteral. Right? So, and then you check prothrombin time again tomorrow, like 24 hours later. So at 24 hours, when you check the prothrombin time, if it goes down by 30%, it means that it was because of vitamin K deficiency and not because of liver. So you may have such situation where prothrombin time may be increased and LFT may be deranged, but you have to find out whether it is because of just plain vitamin K deficiency or whether it is because of compromised liver synthetic function. In that case, you give 1 ampule of vitamin K, phytominadione 10 mg, and then after 24 hours, next day you send in for again prothrombin time, and if it comes down, it means that it was pure vitamin K deficiency. By 30%, right? It is mentioned in Tintinalli's, and if it doesn't come down, then obviously it is because of liver, right? So this was about lab evaluation. Now let's talk about few more things. So this is ascites. Next topic is ascites. Now you have to pay attention because this keeps getting worse. See, in our emergency, what happens is we get to keep patients for slightly longer time. Patients stay in our emergency for 5-6 hours. So we have got the opportunity to observe patients for that much of time. We are able to appreciate that our treatment is, whether it is showing its effect or not, right? So it is slightly easier for me to be able to understand all these things. You also have to go and follow patients whenever you get time. Like if your duty is over, just go to the ICU, take a round once, look at the patients which you have admitted, and then be back. Let's just take a look at the labs and all, right? It becomes easier for us to follow patients because we might not be seeing all these things in our life, but we will have to answer all these things in our exam, and that is what really matters, right? Nobody cares how much knowledge you have until and unless you actually get a degree. So ascites is one of the hallmarks. It is one of the hallmark of liver disease, right? I think that this is not the page, maybe. No, this is not the page. Just a second. Chapter is really long. Chalo, this is not the topic. I'm sorry. Please forget about it. I'm going to just read slightly more about it and then we'll come to ascites because this is the second half of the chapter. We haven't really reached there yet. So, yeah, albumin. Next topic was albumin. So we were talking about all the liver enzymes. So we have talked about AST, we have talked about ALT, we have talked about ALP, we have talked about GGT, we've talked about prothrombin time. Now we are talking about albumin, right? So albumin, it reflects the synthetic function. So if there is acute hepatitis, if there is cirrhosis, then albumin levels are going to be low. What is the T half of albumin? Half-life of albumin is around 3 weeks. Okay, it is a negative phase reactant, right? It is a negative phased. Acute phase reactants, you know, the mediators which increases or decreases in inflammation. So it is a negative phase reactant, which means what? That whenever there is going to be inflammation in the body, levels of albumin is going to decrease, right? Then in malnutrition also it is going to be low. Obviously, we've read this in MBBS also. It does not correlate with the degree of hepatic disease. Now, let's talk about viral hepatitis serology. When I talk about acute HAV, hepatitis A virus, acute HBV, and acute HCV. Do you think that all the three have IgG or IgM or just the antigen? So, acute HAV is diagnosed by what? IgM. If serum IgM for anti-hepatitis A is positive, then it is acute hepatitis A. For acute hepatitis B, we do not wait for antibodies because we know that it may go into chronic phase, right? So for acute hepatitis B, we diagnose it by HBsAg positivity, surface antigen, right? IgM. Here the IgM is anti-HAV. But for IgM and hepatitis B virus, it has to be the core antigen, which is HBcAg, right? So against this, if IgM antibodies are formed, then also we will call it acute hepatitis B virus, right? Then for HCV, IgG and IgM, both are there, right? But there is a delay. So the delay is 6 to 8 weeks. 6 to 8 week of delay is there between the infection and the formation of antibody. So for 6 to 8 weeks, there is a window period when the lab values are false negative, right? So this is what we need to know for hepatitis A virus. For hepatitis A virus, IgM is formed very soon by the body, so we can detect that. For hepatitis B virus, antibodies are not formed so easily, so it is diagnosed by HBsAg or antibodies to core antigen. And for acute HCV, both are there, IgG and IgM, mostly IgM obviously, but there is a window period of 6 to 8 weeks between infection and antibody formation. This week shows false negative results on lab, right? Now, let's talk about ascitic fluid aspirate, right? So ascitic fluid aspirate means what? Ascitic fluid patient who comes with CLD, who comes with liver failure, who comes with liver disease are going to have ascites, right? So for these patients, we can do tapping. Tapping can be of two types, therapeutic and diagnostic, that we will discuss later on. It's there in the notes, right? So what do we see in this tapping? In this aspirate, we are going to look at cell count, we are going to look at glucose, we are going to look at protein, we are going to diagnose SBP. What is SBP? Spontaneous bacterial peritonitis. If the total WBC count is more than 1000 per mm cube, or if the total neutrophil count is more than 250 per mm cube, this is diagnostic of spontaneous bacterial peritonitis. Gram, stain and culture is not very much recommended. Why? Because this is false for up to as high as 30 to 40% of the times. So it is not very reliable. It is not very much recommended. Now let's talk about non-hepatic causes of abnormal LFT. See, LFT is abnormal, but liver is normal. What is the cause? See, if ALP is, we have just discussed this, right? If ALP is increased, mostly it is pregnancy or it can be malignancy, right? If AST is increased, it is secreted by so many, muscle, kidney, I told you so many things, right? So AST can be increased in MI, it can also be increased in rhabdomyolysis, right? Bilirubin is increased in so many things, right? Hemolysis, I told you, pre-hepatic cause, sepsis, abnormal erythropoiesis, right? PT, prothrombin time is increased, and I told you malabsorption syndrome. Then vitamin K deficiency, same. Then antibiotics, some antibiotics may cause it to happen. Then anticoagulation, right? Also hypoalbuminemia. We know so many causes of hypoalbuminemia, right? If you do not know, you must know at least nephrotic syndrome. Nephrotic syndrome is so common. We know that loss of albumin is so high, right? Then enteropathies, protein wasting and enteropathies can be there, malabsorption can be there, malnutrition can be there. We've just discussed all of this, just we are reading it from a different perspective now. So this is all. Now let's talk about hepatic disorder imaging. So in imaging, what do we use? Mostly we use ultrasound, in which it will show grade 1, 2 or 3 of fatty liver, or we do CT. If we are suspecting portal vein thrombosis, hepatic vein thrombosis, etc., then Doppler with ultrasound is the investigation of choice with ultrasound, right? This is it. Then acute, chronic and fulminant hepatic disease. C. This is going to be a huge topic. So right now we'll be completing acute viral hepatitis first. If I have time, then I will continue up to chronic hepatitis. You shall be able to differentiate between acute hepatitis, chronic hepatitis and liver failure. So chronic hepatitis is still something where we as ER physicians can act. But in case of liver failure, we have to call the liver transplant unit and get the patient worked up for liver transplant. So this is the major difference between liver failure and chronic hepatitis. I just understood this after reading it. So let's talk about acute hepatitis. So acute hepatitis can be of two types: acute viral hepatitis, acute toxic hepatitis. The clinical features remain more or less the same, which you must have seen very commonly in your ED: nausea, vomiting. The patient will tell that whatever I eat, everything comes out. Slightly yellowish discoloration of skin. There can be abdomen pain, right? There can be right upper quadrant pain. Then there can be fever. Yeah. There can be hepatomegaly. That is all. So for both viral and toxic hepatitis, these are going to be the common clinical features. Now let's talk about acute viral hepatitis. So acute viral hepatitis. Let's talk about it one by one. First is hepatitis A virus. The transmission, we all know A and E goes by fecal-oral route, right? I am expecting you all to know this. This should be a previous knowledge. Most common transmission occurs from who to who? It occurs from children to adults. Right? Incubation period is 15 to 50 days. Nausea, vomiting, malaise, dark colored urine, jaundice. Does it progress to chronic? No. Chronicity? No. It has no chronic component. This was about hepatitis A. Now